Good afternoon and welcome to the CIHQ Partner Webinar Series. This webinar will be about taking the next steps in the CMS Patient Safety Structural Measure, or PSSM. Oh, Dan, can you forward a slide? Please know that Dan will take questions at the end of his webinar. There's a questions box to the right of your screen with a down arrow. The handouts are also found in a handout section. This presentation is available during the webinar only. So Dan Corcoran is the founder and CEO of SafeQual, an all-in-one software solution for employee and patient safety, quality, and risk management. In healthcare, Dan's industry leadership includes contributions to ASHRM, Ashram, as EDC committee chair, AHRMNY as a board member, HFMA Metro New York chapter as a past board member and technology education committee chair. Dan also speaks on PSSM, HRO, QAPI, and AI related issues in healthcare quality within these organizations. So SafeQual is a partner of CIHQ since early 2023. Dan, you have the floor.
And to all of you for coming to this webinar today, or may view it in the future. I volunteer side by side with some of you, developing educational content for professional credit, and with that education, moving healthcare to be a bit less risky for patients and staff. As today, sometimes I'm the presenter. I've spoken on a number of topics. I have a couple of people that look to me for advice on their professional careers. Rather than advice, I prefer to offer questions people can ask themselves when deciding career changes. Listen for those questions today and use them to help your career as we all work to make healthcare and human welfare better than ever. In addition to volunteering in healthcare, I love to race sailboats and hold my fellow sailors to high standards in preparation and performance. We win races through meticulous preparation, skill building, and maintaining high standards. In my day job, I apply the same approach on the front line of software development. My team and I work to diligently enhance productivity across the healthcare system. The content of this webinar is based on discussions with healthcare leaders, advisors, and my valued staff at SafeQual. We conduct a gap analysis between CMS's vision of patient safety as detailed in the Patient Safety Structural Measure Rule and SafeQual's operational excellence model. This model integrates best practices in healthcare operations with software innovation so we can improve oversight and productivity across all care settings aimed for zero preventable harm. You too may be called upon, as I was, to perform a gap analysis between your healthcare system's best practices and CMS's vision for patient safety excellence. And you may be called upon to be part of a team that facilitates that transition to the new CMS rule, or at least does a gap analysis. Today, I'll better prepare you for that. Today, I will guide you through the next steps and tactical decisions you can make, both for your hospital and your career as you work to align with CMS's vision of patient safety outlined in their rule. Despite significant advances in healthcare, patient harm remains a pressing issue with many hospital settings. CMS's new structural measure rule directly addresses this challenge. CMS believes that by compelling hospitals to prioritize safety through enhanced culture and systems, combined with promotion, transparency, and accountability by them, they can work with you to reduce the overall patient care costs. In essence, CMS is elevating many best practices to become the comprehensive standard for patient safety organized into 5 domains. CMS expects healthcare systems to learn and adopt these new standards by conducting a gap analysis between their current practices and the CMS rule. This involves evaluating your healthcare system against 25 measures, each measure a descriptive statement of performance at exacting standards. Temporarily, CMS is not promoting their vision with some healthcare settings. This gap analysis is not needed, for example, for critical care in certain types of hospitals listed on this slide, like children's hospitals, which are exempt. I mentioned already that CMS is compelling patient safety through promotion, transparency, and accountability. The promotion piece is the gap analysis. CMS promoting their vision of patient safety against yours with a financial penalty for not measuring yourself against their vision and reporting it into the system. There are more teeth to this rule to compel healthcare systems to invest in CMS's vision of excellence and patient safety. We'll talk about them here. Hospitals that fail to implement the measures may lose their edge in competition for talent. Hospitals that fail in implementing the measures in the rule may face reputational harm when CMS publishes their gap analysis in fall of 2026. This harm can follow when newspaper reports written to explain the new grading system appears and when they publish how your hospital measured up. So for example, would it hurt your hospital if you scored 1 on a scale of 5? Would it hurt if news reports listed what was required to receive a score of 5 and it all sounded reasonable? Hospitals in competitive markets may experience lower revenue, resulting if patients choose to go to a hospital rated 5 versus a hospital rated 2 or 1 or even 0. Hospitals may also lose their edge in competition for talent and pride of their healthcare system over others. Will hospitals with a lower score need to pay more to attract nursing talent? In addition to this big stick, there is a carrot in the form of potential performance incentives hinted at, but at this time, they're not defined. You have no promise of more revenue to pay the costs of increased patient safety investment. If this sounds like patients choosing one hospital over another because of a leapfrog or other score, and that does not scare you anymore, consider this could have more bite. The way the scoring system is designed, it is far, far too easy to score a 0 on a scale of 5 points. In addition, if healthcare systems are forced to reveal answers to attestation questions under state law, and that becomes public, it could be damaging to reputation as well. Most of the measures here sound completely reasonable to people that do not have to go into the details of implementing them as you may. In my opinion, it is far more difficult to attain a score of 1 on the 5-point scale with the CMS measure compared to, say, scoring a C with Leapfrog. Scoring a 5 on the CMS measure, even more difficult than scoring an A. This is exactly what I believe CMS wants, something more difficult. Now, if you like how your healthcare system has designed best practices for patient safety into all your processes, and it does not match CMS's vision, you may find this intrusive. You may be scoring 0 when you know in your heart you deserve an A. If you want change in your healthcare system, if you're not scoring well, if you want vacant positions filled or new technology added, you may invite this. You may instead look at this as a tool to get such changes funded over other priorities in your healthcare system. After all, nothing like, hey boss, Under the new rule, on a scale of 0 to 5, we score 0 today. I don't know how much effort is required, but for starters, we need some more people and better data. That could be useful as a tool for you to have the resources you need at your job. So the scoring system provides 1 point for doing everything in each domain. Take the 5 domains, add them up, and that's a total of 5 points. This is a score that will be published in fall of 2026 for the gap analysis done for calendar year 2025. Let me give you an example of a measure in each domain. In domain 1, attestation C is our hospital governing board, in collaboration with leadership, ensures adequate resources to support patient safety, such as equipment, training, systems, personnel, and technology. And in the gap analysis, they're looking for a yes or a no to this, as well as 24 other attestations. Another example of an attestation in domain 1 is C-suite executives and individuals on the governing board are notified within 3 business days of any confirmed serious safety events resulting in significant morbidity, mortality, or other harm. Moving on to domain 2, an example of an attestation. Our hospital has implemented written policies and protocols to cultivate a just culture that balances no blame and appropriate accountability and reflects the distinction between human error, at-risk behavior, and reckless behavior. Being able to say mostly yes to this, not entirely yes, causes you to fail in this regard, scoring a 0 for the whole domain. And every hospital sharing the CMS CNN provider identifier number as well. So the answers are yes or no. Any no in any one attestation in any domain causes a 0. It gets worse though. In domain 3, in attestation D, there are 7 high reliability practices listed. Your hospital needs to have fully and completely implemented a minimum of 4 practices in every unit of your hospital. Any one unit not implemented scores a no for the attestation, a no for the domain, a no for all the hospitals under the same CMS CNN provider number. Going on to domain 4, another example, attestation C. Patient safety metrics are tracked and reported to all clinical and non-clinical staff and made public in hospital units, displayed on units so that patients, families, and visitors can see. Are you ready to have your patient safety dashboards or even a part of the dashboard displayed publicly in every unit? Are you going to use computer monitors or paper to do that? Are you going to document for 5 years what was shown on the screen? Anyone want to hear an example from domain 5? Maybe not. Let's move on. From A Few Good Men, what is that quote? You can't handle the truth. Let me explain how you can score 0. CMS compels you to answer yes or no to the 25 attestations that result when you compare CMS's vision to your hospital's actual practices. You enter that into the software they provide. For each domain where every attestation is yes, you score 1 point for the domain. The reverse is true. If you have any one unit in your hospital that does not comply with every attestation in that domain, you score 0 for the domain. So in essence, if you're doing 80% of the work in all your units, you could score 0. If you are yes for every attestation in 80% of your units, but not the others, you score 0. Even if you're doing all the work in 80% of the units, you score, again, 0. The timelines are very short. The first attestations are for how your healthcare system operated in 2025. A strict interpretation of the rule is that your attestations are from January 1, 2025 going forward and never wavered in the calendar year 2025, and is then entered into the NHSN database form in 2026. A loose interpretation of the rule, if you're answering how your system finished the calendar year in the month of December, may or may not be acceptable. Either way, if your healthcare system chooses to love, to hate, or do anything other than ignore the CMS PSSM rule, you'll be comparing all your patient safety processes against CMS's vision of patient safety going forward. So, do you have the staff for all of it? Will you sacrifice some of the domains so that you're assured your healthcare system will get at least 1 or 2 points in 1 or 2 domains? Do you have multiple hospitals? Will you allocate resources so that only some of the hospitals score above 0? The rule is out since August. It's December. Have you made those decisions yet? Who is your favorite child? With the rest of the presentation, I'm going to offer some potential next steps. First, decide who's the leader of this effort. To jump into the details, to do the gap analysis and not have a leader is just a waste of time and going to lead to burnout. Obviously, a detailed gap analysis needs to be done, understanding the gap between CMS's vision for patient safety and the facts on the ground in every unit of your hospital. That could easily take 16 weeks or longer. So there's several other ideas here you can be doing in parallel. Or you could also consider a quick gap analysis where you determine if your hospital is exempt. For example, is it critical care, children's hospital, etc.? And if not, to take each of the attestations and realistically decide if there is any chance you score better than a 0. This can be quickly done. Next is to work with leadership and understand what the desired score above 0 would be, and if there is an appetite to designate a project management person and additional resources to pursue a detailed gap analysis. Some of the bullet points on this slide may also apply. I will pause a minute to let you read through this slide and answer one question. Would you or not agree? For your healthcare system, this is a major project, a project no smaller than adding a couple of floors to your hospital. I'll give you a moment to answer yes or no. If you decide that this is a major project, let me suggest the early steps to help get a jump on this. First, get a professionally trained project manager that has a record of success in your healthcare system assigned to this big project. Second, work to remove all barriers, hiring staff for vacant positions. And third, look at your technology. If it is obvious it won't be meeting your needs, look to freeze spending and freeze contract extensions, at least temporarily, until you can go back to your vendor with your new requirements. When it comes to software technology, think about the airplane equivalent of getting oxygen for yourself first before you place the mask over any children traveling with you. If you and your team don't have the needed technology for your work, you have to decide between replacing it or immediately or using workarounds. Especially when it comes to providing the KPIs and dashboards that are called for in the PSSM, you may find yourself in a hopeless position. Part of the project plan may call for learning what your current vendor can do for you for a little extra money versus replacing. Some key areas to look at are listed on this slide. For example, can your current technology offer a patient-friendly method for reporting incidents of harm? Is there a feedback loop for reported an incident. Is that accessible outside your internet? Does your incident management support candor, as detailed in the CMS rule? If any of these answers are no, do you want to be signing a 2-year contract extension with that vendor? As part of PSSM, all your patient safety processes need to be documented. Do you have software and workflow to manage the workflow of updating all the touch process documentation and verifying that each unit of your hospital has read and confirmed compliance? This could be easier with modern cloud-based document systems with workflow that tracks approvals and the state of the document. As you work through your project plan, be open to the idea of redefining the leadership roles and staff responsibility in safety, quality, risk, and compliance. This may be another area where technology can be helpful, getting all-in-one software that is used by everyone rather than software that is only used in silos. Also consider how the patient experience will change, especially if you embrace all the stations in Domain 5, called Patient and Family Engagement. Also consider that you may need to give access to at least some of your data to governing board members and patient families. How will you control access and fully meet commitments to protect PHI? If your incident management system is homegrown by your IT department, perhaps consider bringing them into your project on day one. Have them understand the depth of changes ahead. As you pursue CMS's vision of the future, you may want to tap into the current trend of generative AI. If you have seen my recent presentation on when, why, and how to say no to AI in healthcare, you would take away that it has value to you today in the form of the Copilot and ChatGPT versions of this product. This is a time you can use Copilot and ChatGPT to be more effective at your own decision making and generating materials to inspire others to follow you. A starting point is using ChatGPT to assist in utilizing implementation resources available online, leveraging the experiences and knowledge shared by others. There's a ton of wealth of information on the internet about the best practices that have been incorporated into PSSM. They're not necessarily labeled PSSM. You will also use these products to create materials to inspire others to follow you. Each of the bullet points above, for example, were finessed with Microsoft Copilot to fit in the available space and to communicate the message, these 5 messages about a role for artificial intelligence. Assuming talk of PSSM does not have you heading for the door of retirement or a job change, this is the easiest slide of next steps to consider. You can do or at least contemplate all these things yourself. First, consider if you're the leader your healthcare system needs at this time in your role, and if not, will you become that person? Can a strong second in command, someone that can manage details and delegation, allow you to rise to the leadership and provide the vision of what's needed in your part of the organization? Or instead, does it make sense to polish your primary skills through the professional organizations to which you belong? Be that detailed person your organization needs. Also, become familiar with the 25 measures to know what conversations you need to have with your CMO, CNO, safety, quality, and risk management peers, and of course, the folks in compliance you work with every day. Increase your professional skills in using technologies like ChatGPT, dashboards, and project management. Sometimes basic familiarity with each can enhance the value of your primary skills and knowledge of compliance and institutional knowledge of your healthcare system. Learn who your subject matter experts are. Build into any project plan a way to use them to prevent breakage of your existing policies that have been carefully put together to serve your community. Should your staff be leveraging CIHQ and ARS to prevent policy changes in support of PSSM from breakage, policies designed for COP compliance, have your staff become more familiar with what's available in these libraries. PSSM attestations require documented processes. Are you familiar with the best kinds of policy management software that manages the collaboration process of document changes, making edits, tracking approvals? Do you need staff or outsourced resources to be funded in a budget to support your work? This slide gets much harder. For example, how many weeks or months do you need to engage leadership? Do you get leadership armed now to make PSSM part of the 2025 strategic plan, or is it stuck in limbo until after the holidays? Is your budget due next week? Is including PSSM more than you can handle? After all, if you were going to add a couple of stories to your current hospital, you would need the assistance of others, and they would need the assistance of you. Also, has some of your peers already looked at PSSM and with pride in their existing patient safety efforts, decided they are 80 or 90% or more compliant and need only minor tweaks rather than treating this as a project, as major as adding a floor to every hospital? Are you the person that needs to go in and reverse that belief, explain to them there's much more involved here for us to succeed? As I said, this slide gets much harder. This may be the hardest. In this slide, remember domain 4, attestation C. Are your patient safety metrics accurate and useful? Are you ready to display them in every unit of your hospital? Is your senior risk manager okay with having your current KPIs publicly displayed in every unit of your hospital? I bet not. Patient safety metrics are tricky things. For example, an increase in reported patient safety events month over month, year over year, that increase is a good thing. But will the public see it that way? Will professional staff be able to recite a clear explanation to any visitor about increasing events? Or instead, should you be collecting KPIs that are easier to communicate and understand? Can you get to the sources of that data with the technology you have today? Are operational excellence models and their associated KPIs by companies like mine something you can implement before the attestations are due? That makes these difficult next steps important to get started on. Some additional thoughts when it comes to budgeting for this. Are the basics covered? Does the entire patient safety, clinical quality, and risk management staff have the funds they need allocated, not just for their minimal professional education, but to expand it as well as their responsibilities expand in response to the CMS PSSM rule? And finally, some important thoughts here. Many of the 25 new patient safety measures have been recognized as best practices for years with education resources readily available. I extend my sincere appreciation to all of you that may be in this audience that have thoughtfully contributed to enhancing patient safety in any of these ways that have been included by CMS. In fact, congratulations to everyone whose idea has been integrated into the patient safety structural measure. And congratulations to all of you that find the best practices you have been supporting today also in that same measure. This is hard though. the costs can be huge. And there's consideration given when not every best practice is followed, because there are diminishing returns for healthcare systems already performing at 80% to take on the additional measures. Will that cost outweigh the benefit to reach 100%? Can CMS pay for this? Or is it entirely a burden on your healthcare system? To comply with these new CMS PSSM rule, hospitals must invest in training for their staff, software tools, culture, and human resources to implement and sustain the standards implied within these measures. Educational resources from organizations such as ASHM, IHI, and HRQ will become more deeply ingrained into the operations of our healthcare system. Do you have the ability to go use those resources? For those starting this journey, I recommend a holistic organizational change rather than merely adding responsibilities to existing teams. This isn't something that can be done in overtime. Be holistic, be proactive in learning and considering visiting organizations that have successfully implemented the best practices at the foundation of these measures to gain insights and best practices. Thank you. We're going to turn this over now to questions. We'll have Michelle here moderate them back to me.
Sure, yes, sir. Dan, we have a question. Did CMS provide a gap analysis tool for this set of measures? Thank you, Morgan, for the question.
Hey, that's a great question. And while they haven't, you can look to the IHI website. IHI announced yesterday that they have placed on their website, I believe it's ihi.org, such a tool that you can use.
Any other questions? Dan, will you put your contact information on the screen?
Yes.
Okay. So please know that this webinar has been recorded. It will be available by next week on our CIHQ ARS YouTube channel. All of the partner webinars are recorded and posted to YouTube in that way. Dan will also have this added to his library of webinars, so please reach out to him with any other questions that you have. We'll hang on the call until everyone is logged off. Enjoy the rest of your day and happy holidays. Dan, you got a comment. This was very informative. Thank you. All right, everyone. Have a great afternoon. Thank you again, Dan, for this webinar information. Enjoy your conference, sir.
My pleasure. Thank you for the opportunity to speak today.